Assalamu alaikum guys, I hope you all are fine. I welcome you all in my YouTube channel, Your Doctor. So today we will discuss about postpartum hemorrhage. What is postpartum hemorrhage? Postpartum hemorrhage is defined as excessive bleeding from the genital tract from the time of delivery of baby till the completion of postpartum, which is 42 days after delivery. Blood loss greater than 500 ml for vaginal and 1000 ml for cesarean delivery. Major cause of maternal morbidity and mortality. WHO estimated that 25% maternal deaths are due to PPH, approximately 1 lakh maternal deaths per year. Types of PPH. There are two types of PPH, primary PPH and secondary PPH. Primary PPH, excessive bleeding from the genital tract during third stage of labor and within 24 hours of delivery of baby, called primary PPH. Primary PPH incidence in developed countries is 4.8%, which is less than developing countries. Causes of primary PPH. Uterine atony. Myometrial causes include grand multiparity, prolonged use of oxytocin, prolonged labor, uterine overdistension. Placental causes are retained placental tissue, placental abruption, placental previa, and placenta excreta. Genital tract trauma, which is perineal tear, episiotomy, and cervical tear. Coagulation disorder, DIC, idiopathic thrombocytopenic purpura, leukemia. Most 90% cases of PPH are primary PPH. Secondary PPH. Secondary PPH is defined as sudden episode of loss of fresh blood after 24 hours and within 6 weeks of delivery of baby. Occur with incidence of 0.5 to 1.5% in West, and in our country incidence is higher due to purpural infection. Causes of secondary PPH are genital tract infection and retained product of conception, submucous fibroids, choriocarcinoma. Coagulation disorders are rare causes, may be associated with von Willebrand disease. Risk factors of PPH: prolonged third stage of labor, multiple delivery, episiotomy, fetal macrosomia, history of postpartum hemorrhage, grand multiparity, placenta previa, placental abruption, PIH, infection, anemia, polyhydramnios, and prolonged labor, etc. Here we discuss about symptoms and signs in patients when with the PPH. Symptoms are anxiety, thirst, cold, pain, dizziness, fatigue, massive blood loss, passing large clots. Signs are vaginal bleeding, pallor, rising pulse, decreased blood pressure, increased heart rate, swelling in vaginal perineal area, altered conscious level, and maternal collapse. 4 T's of PPH. 4 T's of PPH. 1 is tone, atonic uterus, 70%. Trauma, laceration, hematoma, rupture, which is 20%. Tissue, retained tissue, invasive placenta, 10%. Thrombin, coagulopathies, 1%. Prevention of PPH. Antenatal. Hemoglobin below the normal range for pregnancy should be investigated and iron supplementation considered to optimize hemoglobin prior to delivery. Blood grouping should be done. Intranatal prevention is slow delivery of baby, expert obstetric anesthetist needed, spontaneous separation and delivery of placenta during cesarean section, active management of third stage of labor, examination of placenta, induced labor by oxytocin, and exploration of uterovaginal canal, vital monitoring of patient. Initial assessment. In initial assessment, large bore IV, oxygen by mask, monitor BP, pulse rate, catheterization, oxygen saturation, explore uterus. In this case, we will see the tone, tissue, explore lower genital tract to see the trauma, review history, thrombin, observe clots, laboratory test such as CBC, coagulation screen, grouping and cross match should be done. Management of PPH. How can we manage the uterine atony? By uterine massage. If uterus is soft, massage is performed by placing one hand in vagina and pushing against the body of uterus, while other hand compresses the fundus from above through the abdominal wall. The posterior aspect of uterus is massaged with the abdominal hand and anterior aspect with the vaginal hand. Here is the picture. This is the picture. Uterine massage. Uterotonic agents include oxytocin, ergotolloids, prostaglandins. Oxytocin 10 international units should be injected IM or 10 to 40 international unit in normal saline at the rate of 200 to 250 ml per hour. Methyl ergonovin, which is pivotal in hypertension, and agometrine, dose of 0.2 mg IM, given at the interval of 2 to 4 hours. Prostaglandins, carboprost 0.2 mg IM repeated for 15 minutes for total dose of 2 mg and avoided in asthmatic patients. Misoprostol, administered orally, sublingually, vaginally and rectally. Dose range is 200 to 1000 mcg, 1000 mcg for per rectal. How can we manage the trauma? Trauma such as laceration, hematomas cause significant blood loss which is reduced by hemostasis and timely repair. Uterine repair requires surgical repair. How can we manage the tissue? Classical sign of placenta separation is gush of blood with umbilical cord and slight rise of uterus in pelvis. Here is a complete picture of 4T's management. Placental delivery can be achieved by branded Andrews maneuver, which involves firm traction on umbilical cord with one hand and other applies suprapubic counter pressure. How can we manage thrombin? Coagulation disorder are a rare cause of PPH. These disorders require planning for prevention of PPH. Surgical management of PPH. Exploratory laparotomy. If uterine tamponade don't work. Uterine artery ligation, ovarian artery ligation, internal iliac artery ligation, and hysterectomy. Complications of PPH: fatigue, blood loss, anemia, Sheehan syndrome, Asherman syndrome. Sorry, it's a spelling mistake. Transfusion hepatitis, septicemia, orthostatic hypotension, shock and death. Thank you.